Thank you. Thank you so much for having me. Again, just to give a little bit of background, I am faculty at Campbell Osteopathic Medical School. I'm a geriatric palliative care and hospice physician. And I'm really excited about this project. I never in a million years thought I would be involved in a really amazing community collaboration. So I want to thank a shout out to this college. I never would have, without this college support mentors, I never would have been able to get really involved in this. So thank you. People always ask me, what's a palliative care physician? And I always tell them I relieve suffering and provide good quality of life for my patients with serious illness. And that includes not only my patients, but their families and their caregivers. And so my recent role, I've always worked and practiced in Wake County and live in Wake County. So I only know a lot of my community around me. So for me to go to Harnett, I was really excited to be able to be involved in training future family physicians. There's a wonderful residency program, as well as medical students. So I was really excited about this. As I was building up not only my educational program for my learners, I'm building up my clinical practice. I know a little bit about Harnett, but it was really important for me the last few months to understand the community. We all know to understand our communities, to really understand how I'm going to practice, especially in palliative care. I know there's gaps of care in this field, especially in Harnett. So I literally took a tour of the towns. I would drive around during the day, meeting with stakeholders, meeting with agencies, rehab facilities. I went to civic centers and churches. I needed to really get an understanding of the culture and all that is in the community. But what was really interesting is I kept hearing, especially when I met with agencies like home health or hospice agencies, they were really excited I was going to be there. There hasn't been a program like this. I was building up my palliative care team and the inpatient hospital settings there. But I kept hearing the same thing, is there's going to be some barriers for how I could provide care to my patients. And I didn't really know what they meant, but as I met more people, I heard it over and over again, even from pharmacists. And their point was, the medicines you prescribe, there's going to be some barriers. There's low stock shortage in the pharmacies here. So you understand, I prescribe opioids. Opioids are one of the most important class of medicines that I help improve the quality of life for my patients for serious illness. Think about patients with their cancer and they're getting treatments. My patients with end-stage advanced heart failure or COPD, they have such shortness of breath or dyspnea. Guess what I use to help improve their symptoms, that symptom burden? Opioids. They're wonderful medicines when we know how to use them well and right for the right population of patients. And so with all that said, I started getting actually a little concerned as how was I going to be able to ensure I'm doing right and well for my patients in an area that I was already told there's going to be some barriers, and what was I going to do about that? So as I toured Harnett County the past few months, I started understanding, just like every community that we all work in, no matter where we are in the state, Harnett County is no different. They are seeing the devastation of high rise in deaths from opioid use disorder. And so I had to understand how to grapple with that as I was trying to build up my practice and educate my learners as well. One thing about being an educator, especially, again, really excited to build up our workforce, our future family physicians, was really thinking about how was I going to be able to teach them what I do, and that using opioids are beneficial and helpful for our patients, while also balancing the area they practice where there's a lot of stigma and a lot of concerns with the medications. To be sure and clear about opioid use disorder, I want to make sure we're on the same page when I use that. I don't want to take it for granted that people understand that diagnosis. It is the DSM-5 diagnostic criteria. It's really defined really as a problematic pattern of opioid use leading to really significant clinical impairment or distress. And you have to have at least 2 out of 11 signs and symptoms. I don't want to get into detail with that, but all that to say, it's also been more recognized as a chronic illness. And this is where it becomes important for primary care providers. I know a lot of you all are primary care providers, but believe it or not, as primary care providers, you are caring for, and I know you know that, we just had a great talk today on diabetes. These are chronic illnesses that require long-term medication support to reduce morbidity and mortality. Well, guess what else is considered a long-term illness? Opioid use disorder. It requires long-term support and treatment, and it can lead to increased morbidity and mortality if not well managed. So if anyone's going to be really important to be able to train and educate on how to care for all the members of the community, including with opioid use disorder, it was going to be the future workforce we have, our primary care providers. And so all that to say, I had to, again, being in a role as an educator, I knew I was in a great space to that maybe this is where I can make an impact so that eventually that I could make sure I'm doing well for my patients and population. We all talk about evidence-based medicine. Again, we had a great talk today in regards to diabetes management. And so it's no different when we talk about opioid use disorder. There's evidence-based how to manage these patients well with that disease, that illness. These medications are considered first-line treatment. You can see the medications listed: buprenorphine, methadone, naltrexone. Some of you may be prescribers of it. Some of you may not be comfortable, and that's okay. This is all, it's really new to a lot of us. Because I know I was never trained in residency as a family physician that what these medicines are for. I use these medications actually, especially with methadone, for pain management as a palliative care physician. So as you can see, there's a little bit of training and discomfort for our primary care providers. What is so great about these medications is that they help reduce and eliminate those opioid cravings. They reduce illicit opioid use. They really encourage patients to continue with treatment and improve quality of life. Not to get too much in the weeds, but just looking at buprenorphine, for example, it's a partial agonist. So what it does, it has a higher affinity to bind on those mu receptors. So that, say a patient takes morphine or heroin, that buprenorphine is such a higher affinity to bind to that mu receptor, it won't be displaced. So they won't get that euphoric sensation they're looking for when they take heroin, for example. So that's just a quick little, but really clinically relevant reason why these medications are really effective and can help really improve the quality of life and reducing overdoses for our patients. So I started thinking about, again, in a rural community, we don't have the resources. And again, my colleague talked earlier about when you're a solo practice and you're sometimes isolated and you don't have all these, again, I live in Wake County, I know the great resources I have. What do we do in a community where we don't have that? Where do we go to start thinking about this daunting task? Like how was I don't know what I was thinking, but I was part of a great program that really just empowered me to think outside the box. Well, one, I already got the buy-in. I have amazing colleagues that I work with, faculty that are talented. I have the Harnett Family Medicine Residency Program director was all in to incorporate this education to her curriculum. I have a wonderful colleague at Campbell, you may know him, Dr. Robert Agnello. He helps with chronic pain with integrative methodology, so not just prescribing, but non-pharmacological ways. So I already had the faculty and the support, the buy-in, we were ready to go. So I had to know what are our stakeholders and champions that I could partner with in our community, again, to kind of move forward with this. Well, as some of you may not know me, but I just invited myself to the party. I invited myself to the Harnett Opioid Task Force. It was open, and so I went. It was fantastic. There was literally everyone that needed to be there, literally at the table. You had the leaders for the EMS system, the law enforcement, the public health leaders, school superintendent, hospital CEO. I mean, you name it, everyone was there, except the missing piece. And there wasn't the primary care providers there. That was the missing piece. And so this is where I brought in the Harnett and the faculty Campbell together with the Opioid Task Force, having conversation, meeting with amazing leaders in the community, and knew this was going to be something realistic that we could actually achieve together. The next thing that how lucky is North Carolina, we are so lucky with the great resources and research that we have. And that's where I learned about the NC Star Network, which some of you may be part of or heard of, maybe not. We are so lucky with this great resource. These are addiction medicine specialists, interprofessional, so that's a whole team approach. And they do what's called a hub and spoke model. And again, some of you may be familiar with that and some maybe not. It's a wonderful, innovative way to reach out to those of us in the more rural, underserved communities that want to do better care for our patients. In this case, it's usually the hubs, which are usually your university centers, academic centers with your specialists. And what they're providing for those of us in the more rural communities that are maybe isolated but want to do better care, more evidence-based, is they provide training, all free for us, education, mentorship, and that's the model that I wanted to make sure my team was going to be part of, because that's how I knew we could achieve this goal and do better care. So as you can see, just For those of you who may not be familiar, NC Start Network, again, it's a statewide initiative. There's 3 hubs right now, Mountain AHEC, UNC's, who we're working with, and ECU. I wanted to show kind of where Harnett County is. Those of you may or may not be familiar, but you can see kind of the distance there. But again, this is a statewide initiative. The goal is to expand access to addiction medicine treatment for all and opioid use disorder management for all of our citizens in North Carolina. It's really the safety net. It's been amazing. I can't even thank them enough. Dr. Robin Jordan, the director, and meets with us weekly. They literally walk you through the beginning stages of how to take this on, because again, it could be such an overwhelming task. Things such as education, the stigma, addressing it, acknowledging it, training the entire staff and the clinic, aside from faculty. They help with the initiation, the induction, and stabilization of our patients to start them in an opioid use medication. Once the patient is stabilized, and the stabilization meaning patients are on a target dose, they're not getting withdrawal symptoms, they're doing well, they're getting on with their life, then we take over that maintenance management. And we take care of them as any other primary care physician would do. They have other health needs just like the rest of us. And so this is just that collaborative approach to be able to ensure we're doing right and well. If there's ever a time of destabilization, again, the NC Star, our team at UNC, will take on more of that role, that more active role to ensure we get that patient back to that stabilization. Another concern, again, was making sure patients still with that complex pain issues. How do we deal kind of with more of the complex? Again, we're very lucky. We in our region have, again, working with my colleague, Dr. Robert Agnello, but also Dr. Eric Morse. I think he's here today. Wonderful colleague in Harnett. He is addiction specialist and he is a counselor. He saw the need too for primary care providers in the region caring for his patients. He said they come from me for basic primary care needs, and we needed providers to do this. So he was so grateful to work with us, and he's going to be faculty with us and just a more collaborative approach on how to do right and well as we're training our learners. So I was really excited that we were able to kind of put all this together. I know it can be lonely when we're in the rural, underserved communities, but I think, first of all, being in this kind of an arena together where we can meet each other and engage, I think is very important, because then we can really start thinking about how can we work together even at a distance. There's a lot of ways to do that, and I really want to really have you all think about that when, especially with opioid use disorder, really improving our patients' lives is just as important. So that was our project, and we're really excited about it. We're already doing the educational parts of it, and it doesn't happen all at once. We do one patient at a time, as what was explained to me by our NC Star leadership. So that's where we are right now. Thank you so much.